Good evening for those of you who are joining on the recording, and thank you for joining in, those of you who are joining us in live tonight. My name is Brian Lam. I'm a physician assistant, and thank you for joining us for GAPP's MASLD MASH Community Network. Tonight, we are going to talk about pharmacotherapy for metabolic dysfunction-associated steatotic liver disease. That's the long way of saying fatty liver. Again, I serve as Associate Medical Director of Research here at INOVA. So here I am in Virginia, and I'm glad to work in liver disease for the last 15, 20 years. I also serve as the chair of the APP committee for the Global NASH MASH Council. And so we're going to talk about pharmacotherapy tonight. If you want to record your attendance, you can scan this QR code, and that will tell you more about the MASLD Community Network. You can also scan this QR code, and that will take you to the community network for GAPP. If you don't know, GAPP stands for GastroHep Advanced Practice Providers. It is probably the US's best networking opportunities for APPs in the GI and liver space. Annual meetings in Las Vegas. I'm going to be there. It's going to be great. And thank you to Madrigal for sponsoring tonight's event. There's some disease state education decks and more information about Resmetirom on this website. And there will be also talks by APP leaders like myself from across the nation. So it's a great way to get educated. But tonight, just briefly, over the next 20 minutes, we're going to just have a high-level view of these therapies for MASLD. We're going to talk about our GLP-1 receptor agonists like Semaglutide and Tirzepatide, sold as Ozempic and Wegovy and Mounjaro or Zepbound. We'll also talk about vitamin E, Pioglitazone, and Resmetirom, which is, marketed as Resmetirom. Currently, so before March 2024, a little more than a year ago, we did not have anything FDA approved for treating fatty liver and steatohepatitis. As many of you know, we had all these drugs in phase 2 and phase 3, and nothing could get past the FDA because they're very, 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 very demanding in terms of just really wanting a very high bar for efficacy. So what do we do before March of 2024? Well, we would focus on weight loss, both by diet, physical activity. Some weight loss medications could also be used, like bupropion or phentermine. Bariatric surgery was also advocated for folks who would meet the criteria for bariatric surgery. And then weight loss by other methods, such as the GLP-1s. And, essentially all we had was to tell patients to lose weight. We know that when people could lose anywhere from 7 to 10% of the body weight, we would start to see improvement in the steatohepatitis and the fibrosis. But also we know that, fewer than 10% of people were able to achieve that high bar of 10% weight loss. That was shown in Dr. Villar Gomez's study that was published in 2015 down there. So it's very hard to lose weight. Weight loss is effective, but it's very, very difficult. And, 1 out of 10 folks can lose that, 7 to 10%, but then even fewer are able to maintain that weight loss over a year. So while we always talk about diet and physical activity and weight loss, for obesity control, that is very difficult for most patients. As well, we know that death by cardiovascular disease, heart attacks and strokes, is still the number one cause of mortality in patients with MASLD and MASH. So we always want to focus on reducing the risk from cardiovascular disease. So we want to treat the type 2 diabetes and CV risk factors. So, we always want to optimize care of their diabetes and their hypertension and dyslipidemia. There's a little asterisk there, which is, important to say that patients can take their statins. Maybe have this conversation with every other patient. The AASLD does say that for patients with MASLD, it is safe to take your statin. it might raise your liver enzymes a little bit, but over the last 10, 15 years or so, we know that statins do not cause or accelerate fibrosis progression in the liver. And in fact, the AASLD statement says you can take statins safely all the way up to compensated cirrhosis. And even if you have decompensated cirrhosis, you could still take the statin. It just requires more careful monitoring, maybe a lower dose. But risks for heart attacks are high with MASLD, so take your statin. And finally, in terms of liver-directed therapy, we'll talk about these three medications below: vitamin E, Pioglitazone, and Resmetirom. So in terms before getting into that, we're going to talk about GLP-1 receptor agonists, such as liraglutide, semaglutide, and tirzepatide. The way that these medications work is they stimulate glucose-dependent insulin secretion. They suppress glucagon. Mainly, they work by delaying gastric emptying, so patients, just feel full more, and it also directly acts on the hypothalamus to promote satiety and reduce energy intake. So I tell patients, mainly it works in the stomach by making you feel full longer, and it also works on your brain to make you not as hungry. And there's evidence that it, helps with cravings and things like that. GLP-1s are analogs of the incretin hormone, which is derived in the gut, the GLP-1. And so basically, we're just giving you more of that GLP-1, and it lowers blood glucose and causes weight loss, as everybody knows. What are we doing with GLP-1s here in hepatology practices? Well, we know that the weight loss dose of semaglutide met both primary histologic endpoints. These results were released in November of 2024 at AASLD and was published in New England Journal. 72 weeks of high-dose semaglutide was associated with significant resolution of MASH without worsening of fibrosis and improvement of fibrosis. The difference between the effective dose and the placebo was about 14.4%, so that's pretty good. And so the many guidelines are saying that we recommend using GLP-1s for patients who meet criteria for these, so overweight MASLD patients, and give a higher priority to those with MASH or fibrosis. We don't want to use these for lean MASH because those patients probably should not be losing a whole lot of weight. How do GLP-1s affect our GI providers? We know that one of the main ways that it works is it delays gastric emptying, which increases the risk of aspiration during procedures. So patients are being told to hold their dose of GLP-1s 7 days before their endoscopies. And so this has become standard practice now. I've not seen the guidelines recommend holding GLP-1s before fiber scans, but as you know, fiber scans should be fasting for 3 hours prior, and so sometimes I'll tell my patients to hold their GLPs for a day or two, or just inject it after they have their transient elastography or MRE. Briefly about vitamin E, we've had vitamin E around for a long time, since the Piven study, which was like 2005 or something, and this was done in non-diabetic patients who did not have cirrhosis. The dose that they used was 800 international units per day, and approximately 43% of patients showed improvement in MASH while on vitamin E. Limitations: not all patients responded, and it's you want to be very careful. You don't want to use it in patients with hypertension. This was not done on diabetic patients, so we can't really speak to that population. The guidelines from 2023 for AASLD suggest that vitamin E can improve NASH in non-diabetic individuals. However, the joint guidelines from the European societies for liver, diabetes, and obesity, they do not recommend it due to the limited efficacy on fibrosis. There's also some potential risks, concerns about increased risk of bleeding, but also some long-term concerns about possible increase of prostate cancer. And so, you'll want to have these discussions of risks and benefits. If my patients are interested in using vitamin E, I'll say, why don't you use a low dose of 400 international units per day? You might get some of the benefit, and that might obviate some of the risks. Pioglitazone, in that Pivens trial, it was placebo versus vitamin E versus pioglitazone. And so you could use this in patients with or without type 2 diabetes. That Pivens trial in around 2005 showed, yeah, I'm sorry. So there was, in that main primary outcome, there was no benefit in terms of the histologic features of MASH. However, some significant benefits of pioglitazone were observed in some of the secondary outcomes, especially improvement in cardiovascular risk. The main side effects of pioglitazone include, people will gain, 3 to 5 pounds of weight from water weight. So that tends to be a limiting factor for most patients. You also need to be concerned about an increased risk of bone fractures, especially in those who are currently at risk for osteopenia, osteoporosis. And in the long-term studies, there was this bugaboo about maybe increased risk about bladder cancer. The data is kind of mixed there, but again, you want to have those conversations with your patients. Resmetirom. So as I mentioned, resmetirom was approved in March of 2024. It's improved in conjunction with diet and exercise, and for the treatment of steatohepatitis with stages consistent with stage 2 or stage 3. It's not approved currently for cirrhosis or stage 4. Resmetirom is a THR-β agonist, and it selectively binds and activates the thyroid hormone receptor beta, which is the main isotype in the liver. One brief slide about the mechanism of how resmetirom works. Basically, three things. It helps to defat the liver. It helps improve mitochondrial function, so that improves the metabolism of free fatty acids, and it also has an anti-fibrotic effect, which, improving the function of the hepatic stellate cells. But, as you see there on the left, the main isotype of the thyroid hormone receptor is the THR-alpha, and that's the one that's in the heart. THR-β is the main form in the liver, and so resmetirom works selectively on the THR-β, which is the one in the liver. Resmetirom can be used concurrently with levothyroxine, so patients with stable doses of stable hyperthyroid disease who are on stable treatment, not a problem. And we haven't seen any significant safety issues over the last year and a half. Patients with thyroid disease who are being treated with resmetirom. So that's briefly on the mechanism. We'll talk a little bit about just, the registrational study for resmetirom and safety and efficacy. So this was the study that was first authored by Stephen Harrison and published in the New England Journal. This was the Maestro NASH trial. It was a phase 3 study, and it included mostly F2 and F3 patients. There was a small sliver of folks who had the more advanced stage 1 fibrosis, what we call F1B. It was 966 patients. They were randomized 1:1:1 to placebo versus 80 versus 100 milligrams. Like all the trials in NASH over the last 15 years, the FDA is looking at improvement in the inflammation of the steatohepatitis and then improvement in reduction of fibrosis. And in terms of safety, we know the main side effects are GI-related, diarrhea, and nausea. Even some of patients on placebo in that blue bar on the far left, even placebo had some diarrhea and nausea, but these GI side effects were a little bit more in patients who were taking resmetirom. You'll note there on the far right, those three bars on the far right, that the numbers, the incidence of serious adverse events was similar across all trial groups. Just a brief note for clinical trials, we've had these patients in trials, and if anything happens, if you get into a car accident and end up admitted overnight, if you have appendicitis and end up admitted overnight, that's considered an SAE that has to be reported, a serious adverse event. When you look at the, and this is in the New England Journal, in terms of the serious adverse events that were attributed to placebo or resmetirom, only two were attributed to the 80 milligram dose, 0 to the 100 milligram dose, and 1 to the placebo dose. So essentially, none of the SAEs were attributed to either the placebo or resmetirom. So they're mostly like, yeah, incidental. I got cholecystitis and I had to stay overnight, and that was an SAE. But they were not attributed by the sponsor or the investigators to the drug. In terms of primary endpoints, this is what we're looking at. So on the left, we have the percent of patients who had resolution of the steatohepatitis without any worsening of fibrosis. On the right, we had improvement in fibrosis by one stage. And so you'll see on the left, in terms of resolution of the NASH, the difference between the 100 milligram arm and the placebo was about 20 points. And that's pretty typical of what we're seeing in the NASH drugs in development. So that's a good significant improvement. What we care quite a bit about is improvement in fibrosis. To reiterate, fibrosis is the best independent predictor of long-term outcomes like liver failure and liver-related death. So we really want to see improvement in fibrosis. So patients on placebo had about a 14% improvement in fibrosis, and that's pretty typical. In these NASH trials, anywhere from 5 to 30% of patients on placebo will have improvement, and that's just what happens when patients come in and are seen more regularly by NASH providers and hepatologists in these trials. When you looked at people on the 100 milligram dose in this trial, about 26% had improvement. So almost about twice as many people had improvement in fibrosis by one stage if they were on the resmetirom compared to placebo. And that's a pretty good response when in terms of what we're looking at all the drugs in development for treating NASH. So some practical considerations for managing MASH with resmetirom. So again, it's approved for adults, not for kids. It's for non-cirrhotic MASH. So currently it does not have the approval for patients with stage 4 fibrosis, which is cirrhosis. So you're really trying to aim for your F2 or F3 patients, and you also want to talk to them about diet and exercise because that's how it was approved. Here are the AASLD's guidelines, and this is by Chen and published recently. And so basically look at that green arrow in the middle. You're going to use some sort of non-invasive liver disease assessment or non-invasive test. And so if you're using transient elastography, stiffness between 8 to 15 kilopascals is a safe use. That's probably stage 2 or stage 3. If you're using MRE, those are the cutoffs there. Or if you use a biopsy, anybody with stage 2 or stage 3 fibrosis. A little bit more riskier is down at the bottom. If you have liver stiffness between 15 and 20 kilopascals, you really want to make sure that they don't have cirrhosis. So you want to use some other tests to make sure there's no cirrhosis. And these kind of on the edge cases, this should be done by patients with a lot of experience with resmetirom and treating patients with MASH. On the top there, resmetirom is not recommended in cirrhosis. So if the liver stiffness by transient elastography is greater than 20 kilopascals or an MRE elastography greater than 5 kilopascals, don't use resmetirom. If you have, concomitant active hepatitis B or C or autoimmune hepatitis, don't use it. If patients are drinking excessively, don't use resmetirom. And patients with active, unmanaged, out of control thyroid disease, don't use it. In terms of drug interactions, like with all the drugs that you prescribe, you want to run a check. The main thing to consider, or the most common thing to consider here, is a concomitant use with statins. You'll see that down at the bottom. So you can use a statin, you just can't go above those doses listed below. So for Rosuva and Simba, it's 20. For pravastatin and atorvastatin, don't go above 40. The other ones there in yellow are the ones to consider being more careful about your resmetirom dose and concomitant use. So if patients are on cyclosporin, clarithromycin, or trimethoprim are the antibiotics that you want to consider, and the patients on Plavix or clopidogrel, you just want to be more careful. So again, you want to talk to the pharmacist and run your own drug-drug interaction check. Some other final considerations in the next two slides or so before we wrap up. How long are we going to treat patients? It depends. The Maestro NASH trial is still going on. They have data up to about 3 years for many patients now, and I think they'll go out to about 5+ years. We will need to restage and see if fibrosis and see if patients are improving. And that AASLD practice guidelines on resmetirom use, they do give good guidelines on what labs and non-invasive tests to check during therapy, and they give some guidelines on what kind of response you want to see at 1 year in order to know whether to continue or to discontinue and try something else. But suffice to say, get some sort of elastography or ELF test at the beginning, some sort of evaluation of fat in the liver, either by MRI PDFF, proton density fat fraction, or by CAP, which is that measure of fat by transient elastography. The good thing about the expert panels is most of them are coming to consensus now, and the cut points and periodicity for testing are pretty similar amongst the guidelines out there. Again, as with everything, insurance is dictating what we do and do not do. We will need to look at recommendations, as I mentioned, for how long to continue and when to discontinue. But again, that AASLD practice guidelines is helpful on that. And there are a number of agents currently still in clinical trials, and we will likely have more options in the future. But that is just a brief high-level overview. Thank you for joining me tonight. If you want to go back to that QR code, or if you just Google GHAPP MASLD Community Network, all these talks will be posted up there, along with talks and videos and podcasts from other APP leaders. And that's a great way to get some education and to do some networking. So thank you again for joining me tonight, and have a good night.